Thank you very much, Alan. Thank you very much, Mark. I had the same teaching, Mark, ABC, but you were too kind. It was mine. Accuse, blame, and criticize. But we're going to go to D now, like decide what to do. And part of that is the endoluminal management, which it's not going to focus only on the anastomotic leaks, but also strictures and bleedings as well. So we saw this picture over and over from Cleveland Clinic. As we know, the leaks can occur in different ways. This is the tip of the J pouch leak. The reason I'm defining this is that I'm going to show some management of this, and I want to make sure that everyone is on the board. This is the tip of the J pouch leak. This is the presacral sinus in the back from the anastomosis, can extend really, really up high in the presacral space. Fistula, obviously, to the adjacent organs, vagina or other adjacent organs, and from the body itself, it can happen as well. We have some endoluminal procedures, endoscopic procedures, flexible endoscopic methods to repair these. Clips, over the scope clip is another one. Endoscopic suturing, balloon dilatations, and sinusotomies are some of the methods that I will touch base on today. So first, clips, we all pretty much familiar with that. Single resolution clips, many companies have these. The key is here to be able to really rotate them, to get into the right location and be successfully manage what you need to manage. You need to be able to successfully rotate them. And the key, not from rotation, if it's not from the handle, more so from the sheet where the endoscopist can control it, then you will have much more control. This is a flexible endoscopy. We heard this from the other speakers as well. We always routinely do flexible endoscopy, and you see this is a bleeding that you cannot really ignore. This is a colorectal anastomosis. You see leak test on the right side is our laparoscopic view, but there's a leak. There's a significant nuisance bleeding that you need to take care of. This is when you bring your endoscopic clip in. Single clips usually bring it in. If you ignore this patient, you're going to take back at night or in the morning. Just fast forwarding, just for the sake of time here, we're a little bit behind. You can put one or even bring a second one in. And you really get that good body tissue and get that under control. You can do these bleedings, but also for leaks. This is a tip of the J pouch leak, as I shown in the first picture. Can be really a pinhole defect, and really a single clip can do it. But sometimes these are larger. We have seen in the previous images as well. This is an anastomotic colorectal side-to-end anastomosis. As you see, there's a more chronic defect that requires a little bit more than a single clip. And these tissues, remember always, these are inflamed, a little bit more sensitive tissues. So you got to get a little bit more grasp on these. And OVESCO, or over the scope clip, is a good method to do that. I also want to point out this twin grasper on the left, which on this one wasn't used, but this is something that I recently started to use and really like it. It has a dual function. Jaws independently operate, and in the middle there's a pin, but you can open one side 180 degrees, grab it, and then pull it to the next level, to the side, and bring two edges close together, so really effective. This is a patient of mine recently we operated on. She had an oncological resection for ovarian cancer with debulking and colorectal resection done by a GYN doctor, and was sent to us. Pinhole defect, again at 30 centimeters. And this is us in the endoscopy suite here. My nurse is giving a methylene blue just to diagnose first the problem. And you see, from a pigtail catheter that was put in from by IR, and the injectate, the saline with methylene blue really comes through this area. So no doubt that's the defect. And then we're putting this, just showing here how this OVESCO clip works. It's a cap goes over it, and this wheel, you set it up in a way, and then you just deliver it and nicely put on. So, and then we went back out, set this up, and put the scope. It's a little bit larger, the tips, but you can easily still get up to 30, even to the cecum area, and I've closed many defects with this successfully. And here I used actually, again, injection from the outside. You can exactly see where you need to close. And here I used an anchor tip, which is a different type than the twin grasper. And that goes right into the defect actually, and you're gonna see on the left-hand side, please pay attention here, it opens up like an umbrella, and then that granulation tissue can be pulled into the, again, inside of the cap. At the same time, applying the suction also can help to grasp that defect into the area. And then the OVESCO is delivered. As you see, there's a little bit of ischemia as a result of that because it's a very strong clip. And we are up about now for 5 months and no evidence of any leak. This can be done also for the J-pouch leaks as well, even though it's small bowel, this is successfully applied. How about endoscopic suturing? As most of us know, Apollo has this dual channel device. You can certainly do endoscopic suturing. You can do different pattern of suturings, figure of 8, or in a straight continuous fashion. So this is really where I think being able to close the defects will take us to the next level and into the endoluminal surgery. This will enable us and close defects after the procedures we perform. Here you see that in action, how that's performed. Other things, balloon dilatation and sinusotomies, I want to quickly also touch on. Do really balloon dilatations help in strictures? This is a study from our center. Yes, they do. In a study that done here, showed that it saves surgery significantly compared to operating them right away. So in this study, it was shown that the surgery was delayed with the balloon dilatation for more than 6 years. It doesn't always work. If, for example, in an area like this, very, very hardened and chronic, you might need to do more. And in these circumstances, a needle knife or electro incision can be also applied. Are they risky? This is a study looked at that. Really, the bleeding was a little bit more higher risk than balloon dilatation, but perforation wasn't found to be significantly different. However, when it's compared with surgery, obviously, still it stays much less invasive. Structurotomy was, complication rate was much lower than surgery. So management of complications less invasively, endoluminally, surgery seems to be very attractive. This is another example in drawing how pre-sacral sinuses for the ileal pouch anal anastomotic complications could be treated. So the posterior wall can be incised with a needle knife, and then the edges can be clipped to prevent bleeding. And then ultimately this will be incorporated into the pouch and epithelialized and will disappear. This is how it in real life, the pictures of that, and then these are the long-term results. As you see, the back wall, that cavity is gone, and it's fairly nicely epithelialized. We will be able to do more of these procedures in the future, hopefully with newer enabling technologies to allow us to do more endoluminal surgeries, like some of the companies, Dilumen, Boston Scientific, or Met Robotics, where you can bring instruments in, or even the Da Vinci SP platform can reach up to certain points, which I did an ESD with that, and it's really fast and effective if you exclude the cost. So advanced endoluminal procedures are happening, it will occur, techniques will also evolve, and this should be led by the surgeons, and we can do these endoluminal procedures as well as endoluminal surgery. Thank you very much.